Right. Okay. Welcome, everyone. So today we just going to have a bit of a chat about what we've learned from Lisbon, which is the European Society of Cardiology Heart Failure Association conference that takes kind of is an annual program. So it would be myself, Ronnie Khatib. I'm a consultant pharmacist, cardiology, cardiovascular research, and my colleagues, Dr. Gatenby and Dr. Alex Sims, who are consultant cardiologists in heart failure, who will be sharing with us their thoughts and reflections. And today also we will touch on Heart Failure Academy that we have in Yorkshire and Humber that will be launching very soon, and that will be on our agenda as well. So I'm just going to start with Kate or Alex.
Yeah,
Kate, are you
sorry.
there?
We're having some technical difficulties, Ronnie. I logged in on my computer and it immediately crashed.
Oh
Uh,
dear.
then, then we've just been kicked out of the meeting,
Oh,
and now the webcam isn't working.
all right.
So we can certainly chat though. So maybe perhaps while
Fair if the webcam's not working.
maybe maybe perhaps Ronnie, you could start with the things that you were going to talk about, and we can
Okay.
chat with you while we try and
Gives.
resolve our technical issues.
Yeah, that's fine. I can buy you time by starting with what I've got. So what we did between me, Kate, and Alex, we've selected like some trials or interesting discussions that were taking place in Lisbon. And there will be kind of updates on a variety of elements in terms of heart failure management. So I've selected the discussion that has been happening around fenrinone in specifics. That was my selection. And we know that SGLT2 inhibitors and fenrinone, which is a non-steroidal selective mineralocorticoid receptor antagonist, are now becoming more recommended for prevention of heart failure, not just the management of patients with CKD. As you can see, the evidence for the use of SGLT2 inhibitors and fenrinone has developed over time. So we've had like the use of SGLT2 inhibitors in CKD patient, whether it is the DAPA CKD, EMPA kidney, and there's a meta-analysis looking at the use of SGLT2 inhibitors in patients who've got CKD. What was interesting, of course, from this data that the benefit for heart failure was mounting, and that's why we've got good evidence for use of SGLT2 inhibitors in all types of heart failure, rather than just heart failure with reduced ejection fraction. But what's interesting, and that the discussion around the use of SGLT2 inhibitors also to prevent heart failure. So it's kind of going one step before somebody develops heart failure. The prescribing of SGLT2 inhibitors among patients who've got type 2 diabetes and CKD, and we know that there is an interplay between type 2 diabetes, CKD, and heart failure, and patients who do have type 2 diabetes and CKD, they're at higher risk of developing heart failure as a comorbidity. So there's a shift towards thinking about the use of SGLT2 inhibitors, not just to treat heart failure, but to actually prevent heart failure. The other thing which is interesting in this territory is fenrinone, and fenrinone is one of those drugs that are used again in patients who've got diabetic CKD, and there are trials showing how the use of fenrinone is of benefit for patients who've got CKD, where they slow the progression of CKD and reduce the urine ACR and outcomes generally. But again, the thing which is interesting was coming out from these trials, which is CKD trials, the benefit that fenrinone seems to bring to patients in terms of their heart failure. For that basis, what happened is that there is now a whole and this was kind of discussed in the Congress. There's a whole ongoing group of studies about testing fenrinone to look at the efficacy and safety of fenrinone across the spectrum of heart failure and CKD. So talking about heart failure in specific, we've got ongoing trials. So you've got the fine arts heart failure, which is testing fenrinone in patient with symptomatic heart failure with an ejection fraction of 40 and above. You've got the Redefine heart failure study, the Finality heart failure study, and the confirmation heart failure study as well. I'll talk about those in a second a little bit more. So it was interesting to highlight that similar to the story of SGLT2 inhibitors, where we started from using them for diabetes, moving on that they're quite beneficial for CKD, then heart failure prevention, and the use of SGLT2 inhibitors across the heart failure spectrum. Similar thing has been happening with fenrinone. And For you who just want to just kind of think a little bit about fenrir, and of course we know that we use spironolactone in heart failure, and spironolactone is a steroidal MRA, and fenrinone is a non-steroidal MRA, and there's a comparison between them. So fenrinone is a bulky kind of non-steroidal compound, whereas the spironolactone is different. It's more selective compared to spironolactone. Hasn't got any of the sexual side effects that we see, such as gynecomastia, etc. The half-life is different, and the distribution between kidney and heart is balanced. So there is kind of slight differences between the physical chemical properties of these two drugs. Um, and what we've been finding, that fenrinone was well tolerated, and compared to spironolactone, there was less adverse effects and the same benefit in terms of impact of NT-proBNP. So this is a drug which is currently not licensed for use in heart failure. Most of the data that we had were actually data for CKD, but it's interesting when we zoomed in on patients who had heart failure in the CKD population. It was interesting to see how fenrinone behaved in those patients, and that's kind of what brought in the interest. What is interesting, for example, that though fenrinone can cause hyperkalemia, was probably less compared to spironolactone. The other thing was in terms of its use in renal impairment. Of course, fenrinone seems to have improved renal function rather than deteriorate it. And of course, it seemed to have had an impact of NT-proBNP. Um, they did some kind of further sub-analysis of kind of fenrinone looking and the impact of reducing the risk of CV death and first hospitalization with heart failure versus placebo. And there was evidence to show that actually there is great benefit from using fenrinone. So this is a drug that we developed with the interest in CKD, and now we are seeing the benefit of it in patients with heart failure, and that's why by nature we're moving on developing trials where we'd like to actually look the impact of this drug on patient heart failure. But also, as I was saying early on, is about prevention of heart failure. So fenrinone was kind of associated with uh, um, reduction in new onset of heart failure among patients who have got CKD. So that was another attractive element for this drug. A little bit about the trials that are in the pipeline for testing fenrinone heart failure. So I'll just give a brief description of each one of those. So in the fine arts heart failure, they're looking at the efficacy and safety profile of fenrinone in patients with symptomatic heart failure. Those are mainly people really with mid-range and preserved ejection fraction. So they're looking about patients with LV ejection fraction of 40 or more. The primary outcomes is total number of CV deaths and heart failure events. In the Redefine heart failure study, we're looking at the efficacy and safety profile of fenrinone when it is kind of initiated early on in patients who were admitted with heart failure versus placebo. Again, so this is looking at the use of fenrinone in acute admission and see the impact overall on heart failure. You can see that there is interest in mid-range and preserved ejection fraction simply because at the moment, probably most of the evidence that we have is for SGLT2 inhibitors, and there seems to be a growing hope that fenrenon could be of benefit in this population. The confirmation heart failure study, it looks at the early combination of fenrenon with other therapies, specifically SGLT2 inhibitors, further usual care. So you're looking again about hospitalized patients due to heart failure, independent of ejection fraction, meaning that whether they've got reduced ejection fraction or preserved ejection fraction, we're trying to see whether that makes a difference of those patients had early on. Historically, we're looking at patients with stable kind of in a relative term, chronic heart failure rather than acute heart failure. But this study also will be looking at the use of this combination acute heart failure. And the last study, which is the finality heart failure, is looking at the efficacy and safety profile of fenrenon in patients who symptomatic heart failure, but they are intolerant or not eligible for spironolactone or eplerenone. So trying to see it as an alternative to fenrenon, alternative to spironolactone and eplerenone, just to see the outcomes of that. So these are some of the trials related to fenrenon. That was kind of my main kind of highlight. There's a bit more selections, but I'll probably first hand over to Alex and Kate to highlight their selections. So I'll stop sharing and over. Have you got any slides to share,
Yeah,
Kate?
we have, Rani. I just wanted to ask you a bit about
Yeah,
finerenone.
good.
I suppose it fits into the portfolio of things that we're now looking at being able to modify cardiorenal metabolic risk, although does have a slightly different profile in terms of monitoring over and above the medications that we've used so far. So SGLT2 inhibitors, as we know, if you've got CKD and you're going to use them to reduce your risk of getting end-stage renal disease, you will just go on them, and we know you don't need to recheck any renal function. GPs and primary care are really happy providing ACE inhibitors. I suppose I'm a little bit concerned about how we will manage finerenone, which does, will need some potassium monitoring in those patients.
Yep.
And unlike with heart failure, where we've got, obviously our fabulous community heart failure nurses who are fairly comfortable at titrating medications, I wonder if we're going to need to think about how we set up larger scale projects to be able to get therapies in for modifying cardiometabolic renal risk, particularly if they're needing ongoing monitoring. I wondered what your thoughts were about that, and actually particularly the position that pharmacists might play in that.
Yep. That's a good point and question. I think with fenrenon as well, the dosing is a bit tricky because, like, if somebody's EGFR is 60 or more, like you give 20. If it's less than 60, you give 10. If it's really less than 25 EGFR, you probably don't. So there is a debate at the moment going on around the use of fenrenon in patients with CKD. And at the moment, we're trying to explore its use across the secondary primary care in terms of monitoring, in terms of continuity of care and shared kind of care for initiation. And that's all valid. I think the role of stabilizing patient when initiated on it and kind of transfer of care to PCN pharmacists or practice-based pharmacists, or involving some of the nurses, probably diabetes nurses might be interested in that, would be really an interesting mode of delivery and ensure the safety of these drugs. I did actually put a tweet once asking people for their real life experience of using real world experience. And most of the people who use fenrenon, they seem to, the main thing they worry about is hyperkalemia. And what do we do about it? Others didn't have as many cases of hyperkalemia, so it is going to be a bit of a challenge. And they use, I guess, a potassium binder is going to be probably another thing to think about. But yeah, I agree. That's kind of my thoughts. Probably going to be more involvement of our primary care colleagues, especially practice-based pharmacists. Are probably many of those patients might have diabetes already, so the involvement of diabetes nurses, maybe looking after those patients would be quite interesting.
Yeah, I'm really excited to see what the trials that are being delivered at ESC this year show, because I think Fine Arts is reporting at a late breaking session at ESC, so that will be really interesting, and that of course may open a whole new can of worms with heart failure with preserved ejection fraction.
Yes.
Kind of moving sort of smoothly on, almost as though it was planned, to talk about other diseases that sort of cross the cardiometabolic spectrum. The thing that I've picked as being really interesting coming from the conference this year was the further insights into the STEP-HFpEF programs. So we got new data from STEP-HFpEF and the sort of the collection of trials that are around STEP-HFpEF. So just for sort of updating the baseline, STEP-HFpEF trials, there's largely two groups of patients, all patients who have heart failure syndromes and have obesity with ejection fractions of greater than 45%. And the trials, roughly speaking, are divided into two groups of patients, one who have diabetes and one who don't have diabetes. And if you look at the combined analysis of STEP-HFpEF, which was reported a year or so ago, and then there's been some combined analyses of these two groups of patients. So obese patients with heart failure with preserved or maybe mid-range ejection fraction. We know that treatment with semaglutide, which is a GLP-1 agonist, improves or causes reduction of body weight in these patients who are obese. We know that that is associated with an improvement in 6-minute walk distance. So the data I'm showing you there is a combined analysis of those two trials. And for a while, people, or at least when these studies both came out, obviously we know that semaglutide causes reduction in body weight, and I think people were not particularly surprised that there was an improvement in KCCQ, which is an assessment of symptoms from heart failure with weight loss. You know, if you lose however many percentage of your body weight, if you lose 11% of your body weight, which is about what people on semaglutide lost, it seems to make sense to me that you would feel less breathless. And so obviously, coming on from that, there needs to be some further mechanistic exploration as to whether or not we are just causing weight loss in these patients, and therefore you are improving their symptoms because they feel less breathless, or whether actually you are playing a role in the neurohormonal factors that happen in heart failure. And the data that's come out subsequent to these, so sort of subgroup analyses or pre-specified other analyses, are starting to suggest that semaglutide probably has a role to play in reducing heart failure syndrome, so not just making people feel better. Now, I should point out that that's not been demonstrated in any big endpoint trials, so there's no data at the moment that this reduces your risk of hospitalizations or reduces your risk of death, but there are starting to be some signals from these mechanistic group studies that suggest that maybe this is going to be an important way of modifying risk for patients with obesity who have heart failure with preserved ejection fraction. So we know this is not sort of big data. This is pooled subgroup analysis, that there looks to be a reduction in the time to your first heart failure event if you are obese and you have a heart failure with preserved ejection fraction. As I say, that's kind of subgroup analysis, so can't be taken as being a hard endpoint. But as I said, the trial team have sort of gone a little way into trying to understand whether this treatment has an effect on the sort of neurobiology that happens with heart failure with preserved ejection fraction. And so one of the trials looked at what happened to NT-proBNP when you take semaglutide. And this isn't entirely straightforward. We know that obesity affects your level of NT-proBNP. So because of various reasons to do with obesity. So adipocytes produce neprilysin, which is involved in BNP metabolism. And probably if you've got lots of epicardial fat around your heart, you don't stretch your left atrium, so you're less likely to release natriuretic peptides. There's an inverse relationship between your BNP with heart failure and obesity. So we know that, for example, if you lose weight from things like diet or from gastric sleeve operations, actually your BNP goes up. So suggesting that weight loss itself and the fact that you have lost fat cells, you then produce a higher level of natriuretic peptide. And so what's interesting here is what happens when you give a therapy that causes weight loss. Is it that you're going to see that same change in BNP, or are you going to see different changes in BNP? So that's what this trial was set up to look at. So the effect of semaglutide on NT-proBNP. And semaglutide actually seems to decrease your NT-proBNP. So unlike those studies that have looked at the effect of weight loss surgery on NT-proBNP, where your BNP goes up because you are less obese, actually, the fact that this is having an effect on your natriuretic peptide level does seem to suggest that you are getting some specific heart failure effects in relation to semaglutide. And that was consistent in patients who either don't have diabetes here on the left, or people who do have diabetes here on the left. And I think that's really interesting. The other thing to sort of suggest, or the other thing that this trial suggested, is that if your BNP was higher at the start, then actually you tended to do better in terms of your symptomatic improvement. So suggesting that the worse your definite heart failure syndrome, the more effect you get from semaglutide, which I think is interesting. And those of us who are diagnosing patients with heart failure with preserved ejection fraction and obesity, it is a real challenge. I think you'd agree, Alex, that trying to work out when an obese patient is breathless because they are obese and when an obese patient is breathless because they have heart failure with preserved ejection fraction is really challenging. So the fact that your patients who have got the worst heart failure syndrome, as defined by your highest BNP, seem to do best in terms of their symptoms, I think is quite suggestive that you're getting an improvement specifically on BNP. And obviously BNP being very involved in heart failure, that you're not just affecting weight. So the effect of semaglutide seems to not just be on weight loss in heart failure. We know that there is a reduction in CRP in these patients as well, suggesting that there's a reduction in inflammation. And we know, for example, that the patients who lost the most weight seem to do best in terms of their improvement of quality of life. So in patients who've got obesity-related heart failure, semaglutide seems to reduce your NT-proBNP, which I think is really interesting and suggests that it is different to what is happening even in gastric sleeve operations, which we know, or gastric bypass operations, which we know also have an effect on gut hormones. So I think that in itself is interesting. We know that people who've got those higher baseline NT-proBNPs have got bigger reductions in heart failure symptoms. And I agree. I think this suggests that there is weight-independent effects on heart failure pathobiology with GLP-1 agonists. The other sort of simultaneous publication or presentation that happened suggests similar sort of findings. So unlike the last sort of study that I've shown you, which looked at BNP, this looks at diuretic use. So if you use diuretics, what happens to your diuretic use when you take semaglutide? So the same population, the pooled population of patients with and without diabetes, with obesity-related heart failure with preserved ejection fraction. What happens to these patients who are on diuretics? So this is the baseline characteristics. You will start to sort of notice that patients who've got higher BMIs are on higher doses of diuretics. You'll start to notice that the patients that are on higher doses of diuretics are slightly more symptomatic, all of which makes sense. And you'll start to notice that these patients who are on the biggest doses of diuretics have got the highest NT-proBNP. So these are the patients who are most unwell, which makes sense to me. You're on high doses of diuretics because you've got a more clear syndrome of heart failure. You've probably got more of a fluid overload. And semaglutide seems to have an effect on the amount of diuretics these patients take. So if I move forwards to here, for patients who are on loop diuretics, if you look at the placebo group versus the group that are on semaglutide, the people who are on loop diuretics seem to decrease their loop diuretics throughout the course of the trial, whereas the people who are not on loop diuretics increase their loop diuretics. And the quartiles suggest that those patients who are on the highest dose of loop diuretics, and again, they're the people who've got the highest BNPs, are the people who seem to decrease their loop diuretics the most. So suggesting that where people have got what I think is a more clearly obvious syndrome of heart failure, with it being difficult to diagnose at those lower ends of BNP, that there is this effect of semaglutide on your diuretic use. So if I just move here, we know that semaglutide now seems to reduce your weight. That's very clear. There are signals that there are reductions to your first heart failure event in terms of hospitalizations. There are effects on your BNP, which seem to be independent of weight loss. And if you are on semaglutide and you're on the higher doses of diuretics, you're more likely to get benefit in terms of symptoms, and you're more likely to reduce your doses of diuretics. So I think this is really starting to suggest that we're seeing these events independent of weight loss. And I'll be really interested in what happens moving forwards. I think it's still very clear to me that this is a relatively small number of patients that they're looking at. I'm assuming that there is more data to come on bigger studies, on harder endpoints. But I think this is another really interesting bit of data, and it poses us more questions about the position of GLP-1 agonists in patients who are obese, whether they have diabetes or not, if they have heart failure. Which I think it's the same kind of it's the same area, isn't it, Rani, where we're all talking about the same patients who have the same portfolio of diseases, maybe have different end stages, whether it's CKD or whether it's heart failure, but those apices, those the dialysis and the heart failure are really the things that we're all wanting to try and prevent in these patients. But we're all looking after the same group of patients, whether we're diabetologists or renal physicians or heart failure doctors or primary care physicians who are seeing people with hypertension and probably hyperlipidemia as well.
So interesting. The themes that seem to be coming out is, number one is dealing with heart failure as a syndrome across the whole ejection fraction continuum, and the growing number of trials and interest in managing heart failure across the ejection fraction continuum, and also the interplay between all these cardiorenal metabolic, which seem to be the kind of the shift in thinking across, whether it is cardiology, whether it is diabetes, whether it is nephrology, about thinking about all this interplay. That's fascinating. Right.
Yeah.
Should we pause? Are there any questions from our
you guys can post any questions, or anybody, if you want to ask any question, feel free. I'm not sure if you can use the mic. I think you can't, but you can post the question and answer section. So please do post any questions that you might have about what we've spoken about so far, Fenrenone and GLP-1 agonists.
So we have one question. Is the rate of hyperkalemia much greater than that of spironolactone? Sorry.
According to, well, I don't think there was a lot of head-to-head trials to compare the two, but I think what the data that I put early on, it was like comparing the prevalence to the spironolactone data, and I'm not sure we can extrapolate 100%. The claim is that it seems to be less, but that wasn't based on head-to-head trials. That's more like based on comparing different trials, but of course, different trials have different populations. So we can't assure that for certainty. um, if Kate or Alex have got any thoughts, you're welcome.
No, I mean, I think I reflect that, Rani, that I think we're being told that it has lower levels of potassium, don't we? But
yeah,
whether that turns out to be the case, I mean, it has a different mechanism of action than spironolactone and eplerenone. So, and there's that head-to-head. There is a trial looking at whether those patients tolerant to spironolactone and eplerenone, presumably the major indication will be hyperkalemia in those patients. I suppose that will possibly answer that question for us.
Yeah.
Shall I move on if there's no further?
Yeah, let's move on.
questions?
Well, what are people asking? Fantastic to see all these additional overlapping therapies. It has taken some time for SGLT2 inhibitor to come into guidance for use in varying ejection fraction levels. Is there an indication of when GLP-1 agonists will be coming into heart failure guidance?
Well,
Not yet,
not
I don't
yet.
think.
I think for that to happen, you need harder endpoints, don't we? Really.
Yeah.
I think there's a lot of debate still about obesity and heart failure in its sense as its own syndrome. There's a lot of metabolic leptin issues and etc. with obesity and BNP proBNP dropping. I'm not massively convinced is all heart failure necessarily related. It might just be due to the change in the metabolic profile of individuals. But that's the problem with HFpEF.
There's so many different phenotypes, aren't there?
Varying phenotypes, and it's very hard to know what you're always dealing with. But they're the hard. I think the obesity stroke heart failure group are the hardest to assess because clinically you can't make out the euvolemia or the volume at all. I'm going to move on to go on.
Yeah.
Is there more?
No, that answers the question, I think, which is about same thing about are we in a position to consider treatment with GLP-1 agonists for patients with heart failure without diabetes who are obese in primary care? Was it still early stages?
Well, I'm treating one individual, but not on the NHS for that, and is working very well.
I think the whole issue of management of obesity in this country is a massive topic, and if you are in a position to be able to prescribe it for someone who is extremely obese, well then I don't think you can outside of a tier 3 weight management service in the NHS at the moment. That's what NICE suggests. Of course, the big issue being the lack of tier 3 weight management services.
But a lot of patients are taking that into their own hands. I'm increasingly seeing many patients getting Wegovy from external companies like Asda Pharmacy and Boots are prescribing it, I believe. There's a massive black market for it, which we need to be very careful of. I think I'm quite astounded how you can get hold of this drug actually without a prescription. It's very interesting. I don't know how it should be done in a better way really by the NHS. So I'm going to
move on. Yes.
So thank you for the invite to this, Rani, and thank you for all of you attending over your lunch hour. I'm going to talk about probably a less impactful trial, but nonetheless an interesting one called EasyHF. Now I apologise. Now this trial is not yet published, and I could not get the actual presentation slides. So I've got the discussant slides, but this is about acute heart failure admissions needing decongesting with IV diuretics. And those of you who have dealt with patients like this will know that this is often a a very difficult scenario, especially in those who are a bit more resistant. It's hard to judge what you're doing right, and we don't really have any decent measures, or we have crude measures such as weight loss to guide us on how we are effectively diuresing and decongesting our patients. And this evolution of following natriuresis. So as well as most of our diuretics work by generating a natriuresis, so excretion of sodium in our urine, which then pulls free water into the urine, causing a diuresis. And it's been a guideline in the European heart failure guidelines to measure urinary or spot urinary sodium, looking for sort of a greater than, making sure there's more than 50 mics per whatever it is, moles of sodium in your urine, thus indicating that you're getting a sufficient natriuresis. Now, the problem we have in Leeds, for example, is that is not particularly point of care testing. It takes what, 24 hours to come back, and therefore it's not particularly useful in making rapid adjustments to our diuretic regimes for these patients. So this trial, HF, looked at a single centre. It was prospective, open labeled, but randomized. And 60 patients with heart failure who were congested, who were presented acutely, were randomized up to standard of care, which was basically what we do now, physician-led diuretic regime, or a nurse-led natriuresis guided diuretic therapy. And they had these fairly cheap bedside measure sticks, really, that measured the urinary sodium content and gave an almost immediate figure for the amount of sodium in the urine, and the nurse arm of this trial adjusted the diuretics depending on that cutoff of 50 or less or more. So if it was less than 50, they increased the diuretic regime. If it was more than 50, then they maintained the diuretic regime. Whereas the standard of care arm used the old standards of looking at congestion, looking at how much fluid is in their legs, the JVP, and perhaps their weights. And the primary outcome point was, none of these were massively take home big hitting outcomes, but first was is this effective at making a natriuresis over 48 hours? So their urine was collected during this 48-hour period, and it showed that there was a significant increase in excretion of sodium in your urine using a nurse-led natriuresis guided protocol, which is not surprising given that they were focusing on trying to keep high concentrations of sodium in your urine, but nonetheless it proves the concept of the approach. They also noticed in secondary outcome points that the diuresis was greater over the 48-hour periods. They had a similar length of stay, so they didn't seem to shorten that, but that, bearing in mind this was only over a 48-hour period, we didn't go longer than that. It was safe, and there was no substantial worsening in renal failure in both arms. And the process was liked by nurses, and it was easy to use. And I think we know from bigger trials that monitoring natriuresis and monitoring your spot urine does lead to better decongestion. There's a big meta-analysis, and I think it was Jack last year, that showed that, but it doesn't necessarily affect your mortality and doesn't necessarily affect hospitalizations for heart failure. But as a practical mechanism for sort of looking after and caring for patients on the ward, I was quite taken by this as an option, because we've started to move to using certainly spot urine sodiums when we have patients who are particularly difficult to diurese. And this to me seems it's fairly cheap. It's a fairly pragmatic approach to the patient at the bedside, and gives you a fairly immediate result to allow us to make timely adjustments to patients' diuretic regime. Obviously, this is a very small trial. I think it's always very difficult we've never shown that decongestion or offloading fluid necessarily leads to hard point outcomes, partly because no one's really done a randomized controlled trial of diuretics versus no diuretics, because that's probably unethical, because we know that works. We do have markers to suggest that if you do dry patients out to the best you can, they probably stay out of hospital longer, and they probably live longer. But that isn't that's more an observational study, so there are other confounders there that we can't adjust for. So I thought that was an interesting to note, and maybe, with this very cheap point of care testing sensor, perhaps we might start using that and be a bit more scientific in the way we diurese our patients. and maybe give them perhaps shorter courses of diuretics if we're hitting them harder based on their urinary sodiums. So that was that one. I don't know if there's any particular questions around that.
Excellent. That's quite interesting. It's probably would do with a lot of more point of care testing that gives us results much quicker, which make us able to make intervention and much quicker. So that probably the way forward, more point of care testing, which is reliable, of course. But it's interesting, this study, when I heard it, because it was a simple intervention, but probably was limited by the fact that if we were to implement it without point of care testing, it wouldn't be practical.
No.
So it's fascinating, but
It-
it works. That's good.
Well, and certainly knowing your urine sodium is, I found it really useful in being able to make decisions about patients. And I think the other thing is that there is quite often a little bit of friction over pushing to diureses in the presence of someone whose EGFR is sort of changing. Notice I'm not saying, declining kidney function, because we know that that's not what happens. And I think that having some hard endpoints could really help to facilitate, like you say, a scientific discussion about this, rather than it just being one person's opinion over another person's opinion. And particularly for cardiac nurses, who are sometimes, and I speak knowing that one of our nurses is on the call, potentially going over into environments where they are having to oppose the views of a home team, actually having a hard black and white or shades of yellow possibly test to be able to determine whether people should have increasing doses of diuretics, I think could really help empower better decision making.
Do you think you're going to pilot that?
Well, yeah, it's a good point, isn't it? Because one of the other heart failure consultants at the ESC, when he actually looked up how much they cost. They're dirt cheap, these sensors, apparently.
Right.
It might be interesting to do it, just to help, particularly in those patients who aren't meeting the normal sort of what we expect them to do with the diuretics, the more resistant ones.
Taking it sort of a step further, you could easily see how, if you've got really motivated patients and really well-trained patients who have diabetes check their blood sugar, you could potentially have patients who are checking their own urine sodium and using that coupled with heart failure nurses to diurese patients. You add in, I think that's getting written down as a as a clinical, as an idea for a clinical trial. When you look at the new things, so we're part of a trial of subcutaneous diuretics in the community, which is recruiting from Glasgow. I'm sure Mark Petrie would be delighted to hear from anyone who wants to put their centre forwards to join that trial. But you could easily see how there are ways that we could innovate and keep people out of hospital if they are able to do things like that for themselves.
I'm just thinking the platform we're delivering this on, which is Health Innovation. They're usually always on the lookout for any companies who would like to innovate. So maybe we should ask Health Innovation to put a call out for any companies who would like to help us innovate in that field.
I think it's a very interesting area, isn't it? Because you can imagine the sort of management of patients out of hospital with that would potentially be much better. And it's also, I think, as Kate highlights, it's almost like a reassuring test as well, that you are, when we're asking you to go to 360 of oral diuretics or IV diuretics, it's based on something more than Dr. Sims's whim.
Yeah, and everyone's looking at you like you're a complete crackpot.
And when you get to the 500 mark, everyone's like, "Oh wow, you are crazy now." So, anything on that at all? Any comments?
No questions. I was wondering if any of the nurses on the call would like to ask or comment. They can put it in the Q&A section. When they come, I'll let you know.
Fine.
Next.
Yeah, so I'm gonna change tack now a little bit and talk about a slightly different condition. So as well as a heart failure doctor, I'm also an inherited cardiac conditions cardiologist, and one of the conditions I look after probably more than anything in that role is hypertrophic cardiomyopathy. And some of you may already be aware of new therapeutics in this arena, particularly mavacamten or Camzyos, I think it is the sort of company name, and that is a first-in-class cardiac myosin inhibitor, and works by reducing the contractile strength of the ventricle or the heart, and really boils down to the actual problem with hypertrophic cardiomyopathy, which is excess actin and myosin binding, which leads to this increased contraction and eventually hypertrophy. And the mavacamten trials showed some benefit to patients, particularly those who have obstructive hypertrophic cardiomyopathy due to their anatomy. And they showed that about 30% of patients went from symptomatic to totally asymptomatic, with complete resolution of their gradients in that trial. But that drug does come with quite a lot of difficulty in prescribing. So we need to know about their CYP, the cytochrome P450 genotype, which dictates whether they're a poor metabolizer or a normal or super metabolizer of mavacamten, and that affects the starting dose and how we need to monitor them. And also it has many interactions with other medications that affect your CYP status or CYP activity. It also needs a lot of echocardiograms. So at the beginning, every 4 weeks up to 12 weeks, and then an up titration at that point, leading to more echoes. So it's a really high intensity, high resource consuming medication that we are struggling to get off the ground. But SEQUOIA-HCM is the next one of this, and I'll flip to the chart. So aficamten is the drug that's tried in this, and this basically is a randomized placebo-controlled trial of aficamten versus a placebo, and both on standards of care at that point. It works very similar to the mavacamten. It's an inhibitor of the binding of myosin, and reduces contractility of the left ventricle. They took 282 patients. I'm just going to increase this a little bit. Can't see it. Don't do it like that. Who had obstructive HCM. So there are different types of hypertrophic cardiomyopathy. Obstructive hypertrophic cardiomyopathy tends to be those who are generally have more symptoms and have higher risk. And they were randomized to several doses and placebo, and then reviewed again at 24 weeks. In this study, they used cardiopulmonary exercise testing to measure the efficacy of these treatments. And that is argued on the basis that a 1 point increase in your VO2 max leads to a 21% reduction in your risk of either sudden death or worsening symptoms in hypertrophic cardiomyopathy. And it is seen to be a much more objective evidence with little effect from placebo. So a patient can't easily fool a CPEC study. And this study looked primarily at the change in peak VO2 oxygen, and it showed that there was a mean change of about 1.8 compared to very little in the placebo arm, which, well, 1.7, I should say, which is obviously above that 1 ml per kilogram per minute difference that I was mentioning, that had a significant effect on outcomes for hypertrophic cardiomyopathy patients. And obviously we don't have those later outcomes at the moment, but the event rates in hypertrophic cardiomyopathy are somewhat lower than in heart failure. So you need a much, much larger trial to prove that. And mavacamten really came to the market and NICE approved on the basis of the improvements in their VO2 max. So this sort of, I think, highlights the changing landscape of therapeutics for hypertrophic cardiomyopathy. And I think aficamten being the second positive trial showing particularly symptomatic and VO2 max improvements is quite fundamental. This is arguably the first therapy we have in this condition that targets the mechanism of the problem. Traditionally, we've used beta blockers, calcium channel blockers, or rate limiting calcium channel blockers, and disopyramide, which haven't been particularly effective at reducing. None of them have ever shown to reduce VO2 max. There were some other secondary outcomes here. So we saw that the KCCQ questionnaire, the Kansas City Cardiomyopathy questionnaire, there was some improvements. I don't have the exact data for that, unfortunately, to hand. But again, that just points to an improvement in their patient's symptoms. There was a change, an improved change, or at least one NYHA class in these patients compared to placebo. And there was a clear reduction in the outflow tract obstruction, highlighting the mechanism by which these patients improve. So I think the other really encouraging thing about this medication compared to mavacamten, it was designed specifically not to have any interactions with the CYP system, and doesn't have many drug interactions. There is also data from another sort of sub-study of this trial that showed that the reduction in ejection fraction, which is a concern with mavacamten, because about 5% of patients in that cohort had heart failure or developed a reduction in their systolic function on mavacamten. But with aficamten, actually, the LV ejection fractions did not drop significantly. So perhaps this drug, if it comes to market, will be actually easier to use and more accessible to our obstructive hypertrophic cardiomyopathy patients. So I thought that was just something really interesting to highlight, because this is a totally new field of therapeutics for this condition.
Thank you, Alex. No, it was brilliant. I think the interaction element is usually a bit of a nightmare at the moment with mavacamten, so that's very much welcomed. So everybody, have you got any more questions? So I hope we managed to give you a bit of a snippet and a highlight from some of the important elements relating to the management of heart failure, funeral, GLP-1 agonists, and point-of-care testing for looking at urine sodium to adjust management of diuretics, and is it aficamten? It's called
Aficamten.
Aficamten. Yes. Any questions, everyone? So while you're thinking of some questions, if you have any, I'm just going to share that we're launching a Yorkshire and Humber Heart Failure Academy. Will be properly launched in autumn. And let me just put some slides about that while you're thinking about any questions. Feel free to ask any questions you have. But this is an academy that will be run by our heart failure specialists within Yorkshire and Humber. Alex is leading on that, I think, and Kate also is part of the whole team for the academy. Yorkshire and Humber Health Innovation is supporting the program and disseminating it. It's going to be an exciting academy people can participate in. It's funded by NHS England as one of the projects that we have. We're looking at accessible education, a lot of interactive elements you can use to learn more about heart failure, be it diagnosis, treatment, management, referral pathways, etc. Flexible learning, and content will be like suitable for generalists, not just specialists. And we're hoping to make it more of a practical and collaborative learning. So we're going to have a bit more peer learning through online forums, case studies, clinical scenarios, and real world application. So that's coming up. So watch out for that. So hopefully we'll support and raise more awareness and confidence among non-specialist heart failure clinicians or managing heart failure generally. So that's coming up as well in the pipeline. So I'm just going to go back to the chat. I'm not sure if anybody put any questions. Right, anyone? No? Right, well, if you don't have any questions, we're coming to an end. Any final comments, Alex, Kate?
Kate's had to go, I'm afraid. She's had to go to an MVP. But no, thank you for your time this lunchtime.
No,
I hope it's been of
thank
some
you.
help.
Right. Thanks, everyone. This will be put on the Health Innovation YouTube channel at some point. So if you or any of your colleagues would like to benefit from what we presented today, you can always visit it. If you want a refresher, it will be there as well. Thank you so much. Can other access academy? Yeah, other areas. Yes. We'll make it accessible. Other clinicians can access it. Not a problem. We won't limit it just Yorkshire number. Thank you. Right. Thanks, everyone. Thanks, Alex. Right. Cheers.
Thanks, Ronnie. Take care, everyone. Bye-bye.
Bye-bye.